So today we're going to be talking about mainly about ventricular rhythms. We're going to also touch on asystole and what else here? Idioventricular rhythms too. Okay, so ventricular rhythms. Alright, so when the SA node and the AV node fails, the ventricles take over. Okay, so your impulses then will begin in the ventricles, and they basically work backwards. So the QRS will be wide, and the P waves are going to be absent. Okay, so this can cause really some serious cardiac output compromises, because when the rhythms originate in the ventricles, they generally have a wide QRS. Generally is greater than 0.12 seconds, okay, because they're coming from areas outside the right and left bundle branches. So our hearts are designed to conduct and contract from the top down, from the atria to the ventricles. So when this mechanism is disrupted, we lose our atrial kick and the heart's efficiency is greatly reduced. Okay, so when we see PVCs, one of the biggest things to say is that they're really not a rhythm. They are basically considered a complex with an underlying rhythm. So you'll see them just kind of pop up unless they end up turning into a run, which we'll talk about here in a minute. So a PVC is a singled out place beat that's arising from an irritated part in the heart or irritated site in the ventricles. So the SA node is not affected. So the PVC will not actually have a P wave, but it will have a very wide QRS, again greater than 0.12 seconds. PVCs, if they are unifocal, they're going to look alike, okay, because they're going to arise from the same irritated part of the ventricle that's being annoyed. If they're multifocal, they are going to look different, okay, so some may be upright, some may be down. They're arising then from several different irritated sites. And I want to say I've kind of talked about this before too. So they're more serious if they're multifocal. Okay, if they come into a pair, okay, if there's two of them together, then it is called a couplet. Okay, so two of them together is considered a couplet. And then runs of three or more, or three or more PVCs in a row is considered a run of VTAC. Okay, so you always want to be on the lookout for that. Sometimes there is a compensatory pause after a PVC. So on the lower slide there, or the lower picture rather, the gray one, you can see there's a compensatory pause, a little kind of line there with nothing going on. Okay, so so the rate really depends on the PVC. The rhythm depends on the underlying rhythm. The PVC beats are premature, so this will make the R to R interval a bit irregular. Okay, there is really no P wave in a PVC. Again, the QRS is wide. Oh, I know, I was going to say, so one of the things that where I've seen PVCs sometimes happen is suctioning patients. Sometimes you'll see a PVC because the heart gets irritated. You definitely want to make sure, obviously, that you've pre-oxygenated your person before you suction. That's just a general rule anyway, but maybe hit that button, you know, again, you know, after, even if their sats are okay, just to kind of help hopefully reduce some irritability. The also definitely mention it to the nurse. Sometimes, you know, whether they know it or not, it's just, you know, something worth communicating, especially if it is something new. And then, you know, just make sure that they go away. So I try to be quick, don't spend a lot of time down there suctioning. Try to make it a quick pass. Only doing it if it's necessary. So some of the causes can be caffeine, tobacco, alcohol, ischemia, stress, exertion, CHF, electrolytes, imbalance, acid-base disorders, and hypoxemia. So I'll say it again: caffeine, tobacco, alcohol, ischemia, stress, exertion, CHF, electrolyte imbalance, acid-base disorders, and hypoxemia. So the treatment is going to, we would like to find the underlying cause. Oxygen is definitely a treatment, potassium, and antiarrhythmics. Okay. If there is an acute MI going on, you want to make sure MONA, keep that acronym. MONA is morphine, oxygen, nitroglycerin, and aspirin. Okay. So this is just another example of what PVCs can look like. Bigeminy is basically every other beat. A trigeminy is every third beat. And a quadrigeminy is every fourth beat. So if you hear those terms, that's what that means. Alright, so moving on to ventricular tachycardia. Okay, so this is, again, 3 or more PVCs in a row with a rate of greater than 100 is basically VTAC. Okay, so it has a wide QRS occurring rapidly without P waves. Your rate can be anywhere from 140 to 300. It's regular. P waves are not associated with the QRS complexes, so you cannot measure the PR interval. Again, your QRS is wide. Okay, so some of the causes are some of the same ones that I just mentioned with PVCs: hypoxia, ischemia, an acute MI, electrolyte imbalances. What you treat, how you treat these are depending on the patient as far as if they're stable. If they're stable, you're going to monitor them. However, you want to put the pads on because, sorry, my dog. You want to put the pads on in case you have to cardiovert them. You want to check electrolytes. Consider giving lidocaine or amiodarone. If they're unstable, you want to synchronize cardioversion. So unstable, synchronized cardioversion at 120 to 200 joules. You can go up to 360 if it's monophasic. If they are pulseless, you want to give them a shock and start CPR. Okay. Alright, so here is just kind of showing again a VTAC in a different strip. You're having 3 or more PVCs in a row is then defined as VTAC. Overrides all the pacemakers in the heart, and the patient will most likely quickly decompensate. So I'm going to get the monitor on. Monitor, IVs, oxygen. Alright, so again, if they're pulseless, you're going to treat as VBIB and you're going to shock them immediately. If they have a pulse, you're going to check the pulse, check the patient. Obviously check blood pressure, make sure you have IV access, put the pads on, oxygen. If they're unstable, you're going to cardiovert them. And if they're stable, you're going to monitor them closely and consider lidocaine or amiodarone. So one of the things I want to say about amiodarone, it's also known as cordarone, C-O-R-D-A-R-O-N-E. So basically kind of like the last part of that word, cordarone. That's, I believe, a brand name of it. It can have side effects that include pulmonary toxicity. So it is actually a medication that they will put patients on. However, they have to be aware and they have to be screened for any pulmonary toxicity. And that includes checking a chest x-ray, doing PFTs, including a DLCO. Okay, so on their chest x-ray, they may develop patchy interstitial infiltrates. They can present with a cough and dyspnea if they're on amiodarone. They may have a reduced diffusion capacity. Okay, so those are things that they have to be aware of. That's something that they have to do, like before they start the medication, a pre-exam of the chest x-ray, the DLCO, and then they have to continue to monitor those patients. Okay, so this again is just another view of VTAC. Again, making sure that you're aware those QRS complexes are wide. All the causes I mentioned before, including underlying heart disease, mitral valve prolapse, possible DIG toxicity. Liquid protein diets can actually, you can go into catabolism because you actually start breaking down muscle for fuel or for energy. So the source of the pacer in this rhythm, as you can see with the picture there, is the Purkinje fibers, or the ventricular fibers. Okay. All right. So torsades de pointe, torsades, you'll just hear it called just torsades de pointe, is the twisting of points. So this is otherwise known as polymorphic ventricular tachycardia. So it's basically a form of tachycardia, and there are multiple ventricle foci that are being stimulated with a result of the QRS complexes varying in amplitude, access, and duration around the so this twisting of points is around the isoelectric line, and it is a lethal arrhythmia. Okay. It is characterized by widening and narrowing of the QRS amplitude, and it's associated with a QT prolongation. So associated with a QT prolongation. So if you see a QT prolongation, kind of watch that they're not going to go into torsades. So you can see how it kind of, is wide, kind of taller, then it gets kind of smaller, then there's the twisting of points, so the peaks kind of alternate. So on if you're looking at the top rhythm, you can see after it kind of squishes and then it gets taller mountains again, the spiky parts are up on the top, and then it kind of goes smaller and then it twists, and then the spikier parts are kind of towards the bottom. Sorry, I had to sneeze there for a minute. Okay. So some of the causes of torsades can be hypokalemia, okay, so low potassium, hypomagnesium, or magnesiemia, tricyclic overdose, and an MI, add MI to that. Defibrillation can work, but it will put the patient back into this pattern. So you have to fix the underlying cause, and the most common treatment then is to give mag. So when you see torsades, like in your ACLS class, your treatment is magnesium. Okay. Magnesium helps reduce the muscle contractions. So the cause can actually be reversible. The most common causes are drugs that lengthen that QT interval, such as antiarrhythmics, quinidine, and procainamide are medications that it can be a cause from. Okay, so the most common causes are drugs that lengthen the QT interval, such as antiarrhythmics, which are the antiarrhythmics quinidine and procainamide. Can be some of the cause. Okay, so now we're going to be talking about VFib. VFib is basically a dying heart. This is your rhythm that is going to possibly, hopefully not, but possibly, very highly likely that it's going to precede a systole. Okay, so you have a coarse VFib, where you have kind of more variation on the isoelectric line. So basically, bigger squiggles, and then fine VFib is just like really small little fine squiggles. So basically what is happening is the myocardial cells are quivering and they are not depolarizing. So if you're imagine looking at the heart, it can look like jello that's just kind of quivering and kind of shaking. So there's no pulse, okay, and every waveform looks really weird. So of course, VFib, your waves are generally over 3 millimeters in height. They will transition, it will eventually transition to fine VFib. The coarser the VFib, the better it's going to respond to defibrillating. Okay, so you want to make sure you have prompt defibrillation because there's something actually there to hopefully get them back into a normal rhythm. Okay, there's something there to actually shock. Okay, fine VFib then is considered waves less than 3 millimeters high, and it's not very responsive to therapy. Alright, so we have our causes: acute MI, drug toxicity, hypoxemia. Your treatment is shock, 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 shock. Okay, and obviously CPR. Okay, if you're successful, you want to treat your underlying cause. So obviously you're looking at the patient, see what's going on, and we'll go over the H's and T's here in a few. Alright, so this is just another picture of VFib, but this is part of that PowerPoint where I was talking about how I kind of merged a few of them together, just giving you another view of it. Okay, so asystole. Asystole is otherwise known as cardiac standstill. There's no electrical activity going on. So this is meaning clinical death. Okay, so if you see this on your monitor, you want to make sure that you're checking it in 2 leads, because it could be possibly fine VFib. Okay, you want to you do not shock asystole. Okay, there's nothing there to shock. No shock. All right, so another little view of flatline, though I don't know how many ways you can really look at asystole when it's just basically a line. But again, you want to verify it in another lead. There's just a little blip there. Okay, so you want to, sometimes you'll see this, you'll see they're called PEA, it's pulseless electrical activity. The patient is still clinically dead. Electrical mechanical dissociation is another word for it, EMD, but generally you hear the term PEA. There is a little bit of electrical activity, but there's no pulse. So the heart just is like randomly maybe firing off something, but nothing that's viable. A lot of times this is where they may get the ultrasound out in the ED when a patient comes in, and they'll double check to make sure that the heart indeed is not contracting. Alright, so when you're in PEA, it's important to consider your H's and T's. Okay, so this is one mnemonic or mnemonic, whatever they call it, to kind of help you remember this patch EMD. Whatever is best for you. I sure hope my dog doesn't bark because she just came in here and she's annoying. So patch EMD. So I'm just going to look at this if you want. I like the H's and T's. So I'm going to talk about the H's and T's. It's just another way of arranging basically the same letters. Okay. So if we are looking, let me hold on one second. I found something cool online here. I want to just get back to it. Of course, my computer is acting slow. So if you go on acls.com, a website, there's kind of a nice little table here. It talks about, again, the 6 H's, and there's like 5 T's. So hypovolemia, okay, which you'd want to treat with fluid. Okay, so hypovolemia. Hypoxia, obviously treat with oxygen. Hydrogen ions, which is acidosis, treat the cause, possibly give bicarbonate. They usually don't do that anymore, but unless they're severely acidotic or they know where it's coming from. Hypo or hyperkalemia. Okay, hypo or hyperkalemia. So you want to correct the imbalance. Hypoglycemia. So that's one thing they do right away. They check for a glucose and then replace it if it's low. And hypothermia. Obviously, you want to warm the patient. Okay, so those are your H's. So you got hypovolemia, hypoxia, hydrogen, which is hydrogen ions, which is your acidosis, hypo and hyperkalemia, hypoglycemia, and hypothermia. And then your T's then are toxins. Okay, so treat for whatever specific agent if that's indeed what it is. A tamponade, so cardiac tamponade, so pericardiocentesis would be your treatment. A tension pneumo, so needle decompression with a chest tube. Thrombosis, and that can either be an MI, myocardial infarction, or a PE, pulmonary embolism. So you want to treat whatever per cause. Trauma, and that would be a surgical evaluation. Okay, so your T's then again are toxins, tamponade, tension pneumo, thrombosis, put in parentheses MI or PE, and then trauma. Okay, so that basically kind of covers all the I'm just looking at this list here, this patch EMD. I'm trying to think, tension pneumo, trauma, I guess I don't really so much see on there, but so I like the H's and T's. Alright, so again, you want to look to see what's going on. Treat the underlying cause to help survival. Continue CPR. Alright, now we're going to talk about idioventricular rhythms. Now, these ones always throw people for a loop. Okay, so idioventricular rhythms are otherwise known as an escape rhythm. This is the ventricle's last effort to prevent cardiac standstill. So here your SA node and your AV nodes have failed. They are not depolarizing. There is little or no cardiac output. So these are potentially lethal. So the ventricle myocardium itself becomes the pacemaker, which is your escape rhythm, as a result of the ventricles not receiving other trigger signals. Ventricle signals are transmitted cell to cell between the cardiomyocytes and not by the conduction system. Okay, so that's what's going on. If the rate happens to be a little bit faster, you'll kind of see here in a minute, and I think I have a slide on that, then they're called accelerated idioventricular rhythm, because generally they're pretty slow and they're just kind of random. Okay, so as you can see here, your QRSs are wide, your rate is slow, 20 to 40 about, there's no atrial rhythm, your ventricular rhythm is going to be regular. Okay, so idioventricular, wide QRSs. Some of the causes can be severe myocardial damage following an MI. You might see this after being defibrillated. It also can be a cause from a pacemaker failing or a severe metabolic imbalance. Your treatment then is going to be oxygen, atropine, pacemaker. Okay. All right, just again another view of it. All right, and if it's faster than that, then it's going to be called a accelerated. Okay, so our last rhythm we're going to talk about here are junctional rhythms, and these are actually really originating from the AV junction. So I guess they're technically not a ventricular rhythm, but I did happen to put these under here, just trying to divide up these PowerPoints so they're a little more even, so it's not quite so overwhelming for one. So your junctional rhythm is, again, originating from the AV junction. Okay, so just kind of a reminder that the AV node is a group of specialized cells, and its main function is to delay, remember, the impulses that are coming from the atria to the ventricles that allow the atria more time to completely contract. So under normal circumstances, the sinus node pacemaker predominates. If the AV node is not depolarized by the arrival of a sinus impulse within about 1 to 1.5 seconds, it will initiate an impulse on its own from this junctional area. And this is then called a junctional escape complex. Okay. If you look at that Banner Health guide, that kind of helps explain that too. So I'm pretty sure I took some of those notes from there when I did this last. So look at that Banner Health guide as a resource. It helps explain some of these different rhythms. Okay, so I'm not going to repeat that because I believe it's in there. So the impulse will travel away from the positive electrode, and the P wave will be negative in leads 1, 2, and 3. Or you may not see the P waves at all, but on this particular one you kind of see how they're inverted. Okay, so they're negative. Or they can be buried within the QRS complex. They're generally slow, less than 60, but again, if they are faster, then it's considered basically just an accelerated junctional rhythm. So you may need a pacemaker to treat this. So this kind of explains it here too. If the SA node fails, then the AV node takes over as the pacemaker, and this is the junctional escape rhythm. So this is just kind of showing you what happens. So on the one on the left, you have the sinus rhythm is coming from the SA node, and for some reason it's failing, and the picture to the right, and this is where you get this junctional. So you've got a skinnier, a narrower QRS complex. So that is kind of the difference between the idioventricular. Idioventricular, you have a wide, fat QRS, and these junctional escapes, you're going to have, the junctional rhythms, you're going to have, either way, you're going to have a skinny QRS. Okay, so on this next slide here, it kind of shows it too. So your QRS is going to be less than the 0.12 seconds. So if the AV junction paces the heart, then the atria may or may not be stimulated. Okay, so the electrical impulse must travel then backwards. So that's where you're going to see that kind of retrograde. So a retrograde direction to activate the atria. And I think that's why you get that negative deflection in your P wave. So it's inverted. It can be absent, or it could be after the QRS. Okay, so it's not uncommon to see your P wave after the QRS because of that electrical impulse traveling backwards or retrograde. In leads 2, 3, and AVF, the P wave will be negative or inverted if the atria are stimulated. Alright, so what are some of the causes? Electrolyte imbalance, sick sinus syndrome, which is your SA node disease, hypoxemia, complete heart block, which can cause electrolyte imbalance, can cause a complete heart block. Again, you may be symptomatic or asymptomatic. It's obviously going to depend on your cardiac output. So the treatments are oxygen, atropine, and a pacemaker. And then again, if your rate is greater than 60 to 100, it's considered an accelerated junctional rhythm. This can often be associated with an acute MI. This is a less of an issue compared to just the regular junctional escape, because you have a faster rhythm, so hopefully you have better blood flow, a better cardiac output. So you're going to have, so your uniform P waves are absent, and so is a constant PR interval. Okay, so you're not going to have uniform P waves. Again, some of the possible causes could be ditch toxicity. That is actually the most common cause. Hypoxia, cardiomyopathy, an MI, or possibly valve replacement surgery. So your treatments, you want to check for your potassium level. If your heart rate happens to get greater than 100, then it can be considered a junctional tachycardia. And then you want to slow it down. So you want to give amiodarone, beta blockers, all those OLOL, all your OLs, like metoprolol, propranolol, OLOL drugs, or calcium channel blockers. Okay, so that's going to do it for today. I hope you guys did well on your test, also in your MRE. So now you have a little bit of a break, because this week we just have 3 days of CV diagnostics. So your next lecture then won't be until Friday, and that will be your heart blocks and a couple other little things. See you next time.